Hi, everyone. Welcome and thank you for attending this month's webinar presented by Dr. Patrick Bricey on PFAS drinking water contamination on human health. My name is Nicole Tolvey and I am chair of the membership committee for the International Society of Exposure Science, and I will be moderating today's webinar. For those of you who are not ISES members, please consider joining the society as we offer many benefits to our members, including exclusive access to this recorded webinar and presentation after today's session. A few quick housekeeping notes. In the upper right-hand corner of your computer screen, you will see a control panel. Please note that this webinar is in listen-only mode. Throughout the presentation, you can type in a question or a comment in the questions section or in the chat box, and it will be reviewed at the end of the session. We will also do question and answer at the end of Pat's presentation. As I mentioned earlier, today's speaker is Dr. Patrick Bricey. Pat joined CDC in December 2014 as the director of the National Center for Environmental Health as part of the Agency for Toxic Substances and Disease Registry. Dr. Bricey leads CDC's efforts to investigate the relationship between environmental factors and health. He came to CDC from the Johns Hopkins University, where his research focused on the evaluation and control of chemical, biological, and physical factors that can affect health, with a particular concentration on risk and exposure assessment. Under Dr. Bricey's leadership, the agency has prioritized work on exposure to lead, safe drinking water, initiated new ATSDR actions to address exposure to hazardous chemicals, and has played a critical role in CDC's emergency preparedness and response to natural disasters and chemical exposures. Dr. Bricey received his PhD in environmental health engineering from Johns Hopkins University in 1985, and completed his postdoctoral training at the British Institute for Occupational Medicine in Edinburgh, Scotland. And with that, I will turn the presentation over to Pat.
Hey, good afternoon, good morning, depending on what time zone you are. I'm really sorry for the technical difficulties. We'll try and carry on a little bit more briskly to make sure we get done on time. So have the next slide, please. So this is a brief outline of what I'd like to talk to you about today. We're going to review a little bit about what PFAS are, per and polyfluoroalkyl substances, something about how they're exposed, how people expose them. I want to talk about some initial work and some federal response activities, human health effects, clinical implications, and steps for reducing PFAS exposure. So if I could have the next slide, we'll start with what PFAS are in case people are not familiar. It's actually not an easy question to answer because PFAS are a lot of things. And is the next slide coming up? I'm not seeing the next slide. Is there a problem? There we go. What are PFAS? So it stands for, as I said, per and polyfluoroalkyl substances. So at the heart of this is a carbon chain. No, I want the back, please. I'm now on slide 3. Good. So it's the carbon chain surrounded by fluorine atoms and some functional group on the end. And so the difference between per and polyfluoro is whether all the carbon atoms are saturated with fluorine molecules or not. And so the length of the carbon chain can change. It can be branched. It can have different functional groups at the end. But they all have this carbon-fluorine bond. And you see 2 examples here of the more common legacy species, in particular, perfluorocarboxylic acid, PFOA, and perfluorosulfonic acid, which is PFAS. And the difference is the carboxylic acid N group and the sulfonic acid N group on the 2. Now, there are greater than, we don't know exactly how many, as far as I can tell, chemicals are in this family, but there's certainly many thousands of them. And some people say greater than 5,000 of them. So these things can exist in the environment in many shapes and many forms going forward. Many of them are made purposefully. Many of them are byproducts of manufacture, or they're perhaps metabolic breakdown products as well. So these are very unique molecules because they have a property of being able to repel and attract oil and water at the same time. So they're great surfactants, they're great dispersants. They can be linked together to form a number of important materials like nonstick cookware and other water-resistant coatings. But what's important is that they persist in the environment because that carbon-fluorine bond is said one of the strongest bonds known to man. And they sometimes call forever chemicals because that carbon-fluorine bond, which does not exist naturally, is a strong bond. And many of these compounds, in part it depends on the length of the carbon change, can persist in the body for many, many years as well. So now we have a perfect storm, if you will, from an environmental health perspective, of we're making chemicals that persist in the environment and accumulate in people's bodies. And history tells us whenever we have this situation, it usually ends up to be bad for health effects. So why don't we have the next slide, please? So current evidence indicates that ingestion is probably the primary route of exposure. You can ingest things a lot of different ways, but drinking water contamination is one of them. Once these things get into the water, it moves rapidly through the water since it's water soluble as well. And so it can easily move through water columns and easily disperse across surface waters as well. As a consequence, it can be a problem for fish that you might catch from contaminated water that they can accumulate in fish. You can also get exposed by accidentally swallowing from contaminated soil or dust. So if you track this in from outside and the soil is contaminated, you bring your hands to your mouth. If you're a small child in particular, this is a problem. There's a lot of personal care products in your home that have stain-resistant coatings on them, and that could break down over time, and you could get some on your hands and in your mouth. Many of these pathways, by the way, have not been adequately or extensively studied. Perhaps the most common one is drinking water contamination directly from drinking the water. But we know that it can be in food packaging and other materials that contain PFAS. It's in a variety of consumer products, including cosmetics and some dental flosses going forward. So we encounter these chemicals in many aspects of our everyday life, and that's because they have such extensive use. And many of these consumer products place us in pretty constant contact with these chemicals, which is why you'll see in a little bit, they're almost universally detectable in people across the United States, and we know that from the NHANES data. But there's also a couple of important routes of exposure I wanted to highlight in that box at the bottom of this slide, is that in addition to all these other sources of exposure and other pathways, babies can be born to exposed mothers. They can be exposed during pregnancy and while breastfeeding. So these are important routes of exposure for pre and perinatal exposure routes. Next slide, please. So one important aspect of exposure that we deal with a lot at ATSDR is aqueous film fighting foam and the legacy consequences of its use. So when you have a petroleum-based fire, you can't put it out with water. And so you have to put something on top of the fire that will essentially suffocate it, isolate it from oxygen, and put the fire out. And these foams have been used for many decades for that purpose. They're very effective. And in many cases, they were legally mandated to be used. And over the years, as you see in a slide like this, people would train and they spray the foam on fires. And when they're done, they wash it off the waterway, off the runway, or whatever surface it might be putting the fire out on. And it gets into the ground, it gets into the groundwater, it gets into surface water. So there's a legacy of this use that we're still dealing with today. In many cases, these are Department of Defense facilities, but not exclusively. There's many places that use firefighting foam, including municipal fire departments and other industrial sources as well. But the military bases are an area where there's a lot of concern, and they've identified more than 600 military bases that have used firefighting foam, and they're potentially therefore a source for water contamination. And many of the sites that we are helping with at ATSDR are military sites. Now, obviously, there's now a big interest in moving away from PFAS-containing firefighting foams, and that's an active area of research going forward. And it's something that people are pursuing aggressively. Can I have the next slide, please? So just a little bit of history here. So this goes way back. So PFAS were first synthesized for production in nonstick coatings and water-resistant products or stain-resistant products back in the 1930s and 1950s. So in many cases, water contamination in these communities, is 30, 40, 50 years perhaps in the past. So that means these exposures have been ongoing for a long, long period of time. So if we jump forward to 1968, that's the first evidence that PFAS in human serum was observed. In the 1980s, there are preliminary tox studies on rodents suggesting possible health effects. In 1999, through our NHANES data at the National Center for Environmental Health, the other group that I had, PFAS was detected in greater than 90%, 98% of the serum samples. So now we have the situation where it's essentially a universal component of all our bodies going forward. There was some concern about some industrial facilities in the early 2000s, resulting in a study in 2005, the so-called C8 panel study, that began to review human data from exposure in the mid-Ohio Valley. This is the study that was the subject of the movie Dark Waters, if you saw that movie. Concern increased such that the 8 major manufacturers of PFOA in 2006 agreed to phase out PFOA compounds, and PFOA and PFAS compounds have been voluntarily removed from commerce as a result of these concerns. If I can have the next slide. So this slide shows us a couple things. So this is an example of the blood lead levels of most common PFAS in people in the United States from 2000 to 2016. This comes from the 4th National Report on Human Exposures to Environmental Chemicals. This is the report that we published out of the National Center for Environmental Health. And these are based on data from the NHANES sample. And you see a couple interesting things. So the PFAS levels, for example, if you see from 2000 to 2016, have declined drastically. So this just shows that this is actually a good news, is that when you voluntarily stop using these chemicals or produce these chemicals, the exposures in people go down. And so that shows that moving to safer alternatives or different alternatives can lead to successes. Now we see less decline in the PFOA and little decline in PFHX and PFNA going forward as well, because the PFHX, the hexane sulfonate, and the nanoic acid PFAS chemicals have not been voluntarily as aggressively phased out. Have the next slide, please. So our colleagues at the EPA have led the way in many regards in this effort through water sampling that they require as part of the non-regulated contaminant monitoring rule. And so we see a brief summary of this sampling based on this slide. So if you look at the far left, we estimate that it's been estimated there's as many as 51,000 community water systems in the US. Now the UCMR3, this EPA sampling mandate, has a target population that they have to serve a greater number of the people to get sampled. And so as part of this, approximately 5,000 water systems were sampled as part of the EPA unregulated contaminant monitoring rule requirement. And so all the other water systems were not sampled because they were too small. They didn't meet the size criteria. So of those 4,800, approximately 4,600, it was not detected. And obviously there's a limited detection issue associated with that. But there was 129 water systems where it was detected below 70 parts per trillion. And I'll come back to that 70 parts per trillion in a minute, but this represents the EPA's long-term health advisory value for PFOA and PFAS. So approximately 129 systems were detected below that 70, so detected below that, and about 65 community water systems were detected above 70, represent about 6 million people. So between 6 and 10 million people have PFAS in their drinking water at some detectable level going forward. Now, if we look at the number of private wells, there's 13 to 15 million households in private well. We're representing 33 to 38 million people that we don't know a lot about. They're not systematically assessed. And we know that there's about 60 million people who have water systems that are much smaller than the minimum for the UCMR3 sampling. So there's actually a large fraction of the US population. We don't know a lot about what's in their drinking water. And the more we learn, the more likely it is that we're going to detect those contaminations going forward. I'll come back to that. But already based on this data, which are now a few years old, we're talking about tens of millions of people who have contaminated drinking water with PFAS chemicals in the US. So if I could have the next slide. So this is a map produced by the Environmental Working Group, which is an advocacy group, and this indicates places where PFAS contamination in the water has been detected. And this uses a broader definition of detection than we talked about before. And so you see across the US, there are many dots on this map, and don't pay attention to the color too much, but they represent, different aspects of sampling. But I just want to draw your attention to Michigan. So Michigan looks almost totally occluded by color, by dots, and that's because Michigan has been very aggressive at looking at surface water, drinking water sources, groundwater sources for water, and they've obviously detected it almost everywhere they've looked. And so the reality is that these compounds are everywhere, or they're very commonly occurring in water systems. And if more states were as aggressive as Michigan, I think we'd see this map be filling in more. But the point is that there's probably, not tens of millions, but there's maybe as much as many tens of millions or approaching 100 million Americans with these chemicals at some level in their drinking water across the country. So this is part of the problem, is that the exposure is ubiquitous, just as you would expect it would be based on we know that it's in everybody's body going forward. So can I have the next slide, please? So I just want to say a few words about the C8 study. And so the C8 study was a study of contamination around this DuPont facility in the mid-Ohio Valley on the border between West Virginia and Ohio. And if you watch the movie, you'll get a lot more detail about it, but it deals with PFOA and the contamination, the legacy contamination PFOA. And without going into a lot of detail, there was a lawsuit that resulted in a settlement that called for a study to be done on the health effects of these community going forward. So can I have the next slide? In this health effects study, you see some pictures of the investigators, and this was something that was carefully negotiated as part of a settlement. But the study, it concluded there were probable links between PFOA exposure and the health effects you see listed here. So it's high cholesterol, ulcerative colitis, thyroid disease, testicular cancer, kidney cancer, and pregnancy-induced hypertension. Now, for the purpose of this study, since it was a legally mandated study, and they're really looking at what recompense the community members might have, they define probable link as given the available scientific evidence, is more likely than not that a connection exists between PFOA and PFAS. So this doesn't meet necessarily the scientific criteria that scientists would have, but some of these endpoints were, in fact, statistically significant. Others had this probable link associated with it. But nonetheless, this got a lot of attention, and that caused groups like ATSDR, our effort in the Department of Defense, to look a lot more carefully at what their exposures are and how do we address those going forward. Have the next slide, please. So if we just look at the federal response from 2009 forward, so the EPA 2009 Office of Water established provisional health drinking water advisory levels. So they're provisional, so they're essentially draft, if you will. And this year also, ATSDR released its first toxicological profile for perfluoroalkyl substances. So ATSDR has a mandate by Congress to summarize the literature in documents we call toxicological profiles, and where there's enough literature to establish what we call minimal risk levels. And we'll talk a little bit more about that in a minute. And so in 2012, EPA required all community systems greater than 10,000. This is where they started doing the water sampling. In 2013, the C8 panel concluded its results. In 2015, ATSDR, we released our second draft of toxicological profile. This is a document that's had a very circuitous path. Then EPA published the final value, the final lifetime health advisory values in 2016, and they established the 70 parts per trillion. So what they basically said is that 70 parts per trillion is the level that they'd like to see water systems be below. And what they concluded was that both PFOA and PFAS are additive, so that 35 parts per trillion and 35 parts per trillion of the two add up to 70. So any addition of the two for PFOA and PFAS that exceeds 70 would be in excess of a lifetime health advisory. Now, this is not a standard, if you will. This is an advisory value. Nonetheless, it gets a lot of attention, and it's an important benchmark that water systems use across the country to make decisions about what they need to do with their water systems. So in 2017, ATSDR added PFOA, PFAS, PFNA, and PFHXS. These 4 compounds to the ATSDR's substance priority list. And what that does is it gives ATSDR the mandate then to produce a toxicological profile that includes all 4 of these compounds. And we published in 2018 a 3rd draft of our toxicological profile for these chemicals. And also in 2018, ATSDR received funding to do exposure assessment health studies from Congress, and I'll talk more about that in a minute. And from 2019 to present, NCH and ATSDR continues to investigate the relationship between PFAS and human exposure and human health in communities impacted by water contamination in particular. Have the next slide, please. So I want to say a little bit about the EPA long-term health advisory because there's some confusion about ATSDR's minimal risk level and EPA's long-term health advisory. And so the non-regulatory level used by state and public health authorities, to quote here, it's reasonable health-based hazard concentrations above which action can be taken to reduce exposure to unregulated contamination in drinking water. So recognize that these levels are not currently regulated. But this does provide an important benchmark that communities can use when they're deciding what to do about their drinking water and contaminations that need to be cleaned up. So they're developed by taking into account animal studies, using typical toxicological efforts and human health studies, and they published their provisional levels in 2009. And the next slide, you see the provisional levels were 400 parts per trillion, 200. And then the final health advisory, EPA identified concentrations of PFOA and PFAS in drinking water at or below which adverse health effects are not anticipated to occur over lifetime exposure. And this is the 70 parts per trillion values that we have today, recognizing that this is for PFOA and PFAS. And remember, they're additive going forward. And these are advisory levels, but nonetheless, as I've said, they're important benchmarks that water systems use and other people who manage water systems like the Department of Defense use as well. Kind of the next slide, please. Now, there's some confusion about ATSDR's minimal risk level. So as part of the toxicological profiles, as I mentioned, that ATSDR is mandated to produce a document that reviews the literature and distills that literature into what we call a minimal risk level. Now, the minimal risk level is a screening value that ATSDR uses when we go to a hazardous waste site. And so, for example, we would go to a hazardous waste site long before PFAS existed, and there are hundreds of minimal risk levels that we publish over time. And there are benchmarks that we use that we think that below this level, we're pretty certain there isn't going to be a health effect. Above it, there might be. And so we use it really to triage chemicals not to worry about, or to triage sites we don't have to worry about. And so by being above our minimum risk level doesn't necessarily mean there's a health effect, but it just means we want to look further. So there's a inherent conservancy that we build into MRLs that isn't built into the long-term health advisory, but we don't think our values call into question the EPA's long-term health advisories, but they're really just numbers that we use, like I said, to triage things. We might come into a site, there could be 20 or 30 chemicals at a site we have MRLs for, and if 10 of those chemicals are below our MRLs, we just quickly say we're not going to look at them. If the other ones are above that, those are the ones we focus on. So it's really meant to be, there's a conservancy built into that, as I mentioned before. And some people are concerned that our values are lower when you translate them to drinking water values than the EPA long-term health advisory. But in reality, we think they're meant for different purposes, and we don't intend our values to be used as water system guidance values for people to clean up water systems or to make decisions about whether the water system is safe or not. They're meant to be used by ATSDR and our state partners in triaging exposures to hazardous waste sites. So I just want to make sure that was clear if we can. Next slide, please. So ATSDR's job is to investigate health effects at hazardous waste sites, hazardous waste releases, and hazardous waste spills across the country. And they do that by doing health consultations and health assessments across the country. And so they've been doing this for many things for many years. and PFAS has grown to a large part of our portfolio these days. And so we have some resources from Congress that specifically asked us to look at the health effects and exposure response relationships for PFAS. And we're doing this by doing a health study across the country, but we're starting with a pilot study in Pease Tradeport, which is in New Hampshire. And so we're developing our methods at a study in New Hampshire, and we're rolling out a multi-site study, as we'll talk about in a minute, across the country, looking at relationships between exposure and health, very similar to what was done in the C8 study. Now, Congress also asked us to look at the relationship between how much is in people's drinking water and how does that translate to what might accumulate into your blood, recognizing that there's PFAS from all these other sources you might have. The drinking water is one component of it. In places where the water is contaminated, we think it's a significant component of your body burden, but we're not quite sure what that means. And so we're doing exposure assessment. I'll talk more about that in a minute. In addition, we're developing tools and resources. We're engaging communities because we can't do our work without engaging communities. We're working with state and local health departments, and we have a wide variety of other PFAS projects we'll touch on briefly as well. Next slide, please. So in addition to the health studies and exposure assessments, which I'll talk about in more detail we're doing, so ATSDR is just involved with this site work that I mentioned before. So we're currently consulting or working alongside our Department of Defense colleagues and our state partners to address PFAS contamination of 40 communities across the country as we speak. And we can do this because they're national priority list sites. ATSDR is mandated to do that. We can do it because we get asked to from the Department of Defense, we get asked from a local health department, or we can be petitioned from community members to get involved with the site as well. So when I first started ATSDR over 5 years ago, we had one site we were dealing with PFAS. And you see now over a few short years, we're working with 40 communities across the country right now. So this has become an important part of ATSDR's portfolio of site work. And you see these sites range across the country from the East Coast, to the Ohio Valley and the Mountain West and the West Coast, and a lot of sites in Alaska. Many of these are Department of Defense sites, but not all of them going forward. Kind of the next slide, please. So now, a few years back, 5 or 6 years back, when this started getting hot, people knew that we could measure how much PFAS was in their blood. And not too long ago, our lab at the Center for Environmental Health is the only lab that would routinely do this work, because we do it for NHANES going forward. And so we were being inundated by requests to provide blood testing to communities across the country. And rapidly, over a period of months, all of a sudden we had requests, and we added up, there's communities, potentially millions of people wanted blood testing done. And of course, well, we resisted that because there's no health-based threshold from which to compare a blood level to. So, but on the other hand, we thought we wanted to know something about what does it mean to drink water from a more investigative perspective, and how does that translate to what builds up in your body? And we thought we could do that with smaller numbers of people, and we can do it in a systematic way, and we can address that concern. So if we understand the relationship between drinking water and build up in your body, people can infer from themselves without having to test everybody. If you think there are 60 million Americans, or 50 million, or 100 million, or 20 million, depending on whose estimate you think, potentially exposed to these things, there's no way there's enough resources in the country to offer blood sampling to all those people, nor do we think it's advisable going forward. So what we've done is we see a number of communities here across the country where we're coming in and we're doing a statistically based sampling. So we're identifying people and we're collecting their blood, we're looking at their water, we're collecting their urine, some of the shorter chain chemicals you can measure in urines, and we're understanding what the relationship is between contaminated drinking water and body burdens of these chemicals going forward. And you see the communities here, we're doing that from Spokane, Washington to El Paso County, Colorado, and up into Fairbanks, Alaska, as well as the East Coast. Next slide, please. So this is the process we follow. And so we developed this process. We have this toolkit for this, all published online, so it's available if anyone wants to use it. And so what we do is we come in and we talk to a community about what we're doing, why we're doing it. Like I said, community engagement is the heart and soul of what HSDR does. Households are randomly selected to participate. So now it's not a convenience sample, it's a representative sample is our goal. We visit houses and we collect blood and urine, and a subset of samples we call houses, we collect water samples from their home as well. And then we analyze the samples for what's in their blood and urine, and we publish all our analytical methods online. We publish all our questionnaires online, so anybody can reproduce this themselves. All our methods are online. We send individual test results back to participants, like you're morally obligated to do. And we have letters of transmittal that we publish online, so people want to do this, they can see what we send. And then we write a report that looks at the whole community, and then we present the community results to the whole community. So people get their individual results and the community get the results. And so this is a systematic process that I think we want it when local health department says, please come in and measure PFAS in our blood. We discourage people from just doing convenience sampling where they just say, anybody wants to have their blood drawn, come on down, we'll sample it. We think we want to do a representative sample, because what this allows us to do, this is important, is that we can look at one community to another, we can compare across communities, and we can also compare within communities over time if it's representative. Are things going up? Are they going down? Is this community higher? Is that community lower? If this is higher, why is it higher? You can't do any of that with a convenience sample. So like I say, we have this as a toolkit we have on our website. And next slide, please. So this is just a representative data from 2 of the sites that we've done. And this is from, actually, this is just data from one site, Pennsylvania. And so you see, this is just data from the 4 most commonly detected compounds: PFOA, PFAS, PFHXS, the hexane sulfonate, and the nanoic acid one. And here you see, just to set this up for you, you see on the left-hand side, you see the results of the PEAT, stands for the PFAS Exposure Assessment toolkit. And so we come into a community, instead of measuring thousands of people, we measured 235 people to get a representative sample. And you see here the geometric mean, you see the confidence interval, the median, and the range in those communities. So we characterize for all these things. And just for perspective, we give the NHANES results. So remember, NHANES is data that's collected over time. And the more relevant NHANES data is probably the 2011 to 2016 data, because this was done in 2018. And so you see, for example, in this community, PFOA is a lot higher than the regular country compared to the geometric means. For PFOA, 3.3 versus 1.6. PFAS is 10 versus 4.7. PFHXS is 6.64 versus 1.2. And PFNA is about the same. And so this is a community that was impacted by firefighting foam. This is a military site around this community. And PFNA is probably not a big component of firefighting foam. Well, it's not really sure, because the components of firefighting foam have changed over time, and they're consumer, commercially private levels, so they don't tell us what's in it. So we're not quite sure what's in firefighting foam. So now within each community, since we don't have health benchmarks to compare these two, we can at least say, how do you compare to the rest of the country going forward? And so we feel this is useful information. Now, what we hope to do with these data is now look at the relationship between what we know about each of these samples. We know what they did for living. We know what water source they drank from. We know what was in the water source they drank from. We know how much water they drank. We know something about some other consumer products they used. And we hope to come up with a statistical model now that estimates the contribution of the water to what's in a person's body. In addition, knowing kind of what the excretion rate for these chemicals are important. And for PFOA and PFAS, we have a good handle. For these other things, we don't. If we come in at another point in time and we do this again, we'll be able to estimate what the excretion rate is. And knowing something about the biokinetics of these things in people's bodies will also help us understand the length of time it will take for exposure to decrease should the drinking water be stopped. Can I have the next slide, please? So my computer Is there a problem with the presentation? Okay, great. So now let's talk about the health study. So we wanted to look at the relationship between chemicals and health outcomes, similar to what the P study did, but we wanted to have, a large enough sample size. But there's our initial concerns. We're probably the community we spent most time in is this community around the Pease Trade Port, which is a former Air Force base in New Hampshire. And so we began a study there where we're looking at this relationship between health outcomes and PFAS exposure. We're in the process of recruiting people for that study and collecting data on that study. But unfortunately, given the situation we're in today, we've had to put all that work on hold going forward. So we'd hoped to be done with this study within 2 years, but now we're worried about what that might be. Can I have the next slide, please? And slide 22, please. Is it possible to get the next slide, or did we lose everybody? My computer's been kludgy. I hope it's not me. Great. So what we want to do is now take the protocol we've developed and we've implemented in Pease, New Hampshire, and look at it over across the country. And so we hope to enroll across the country over 6,000 adults and 2,000 kids. And we'll again sample their PFAS in their blood and their urine, and we'll do a lot of health screening to look at kind of the relationship between a wide variety of health endpoints, similar to what the CH study did. These health endpoints include thyroid levels, cholesterol levels, liver function, kidney function, and so forth. And the sites we're looking at are, we have a site in Colorado, a site in Michigan, a site in Pennsylvania, a site in New Jersey, a site in Massachusetts, a site in New York, and a site in California. These awards were made competitively by people who submitted applications to participate in the multi-site study. Can I see the next slide, please? That work, by the way, is also on hold as we deal with the COVID-19 response going forward. There seems to be a delay between the slide changing. So the next slide is going to show us some of the additional work that we're doing on PFAS across the country. And so we're also looking at how do we do retrospective exposure assessments, because in many cases the people's exposure has stopped. So how do you estimate what people were exposed to in the past? We're also looking at cancer in communities. The multi-site study won't have enough sample size or power to look at cancer. If you remember, kidney cancer and testicular cancer were two concerns raised in both animal studies as well as in the CH study. We're also looking at how communities respond to psychosocial stress around chemical exposures. And like I said, we're also developing pharmacokinetic models so we can better estimate how things leave the body over time. And this will help us also with our historical reconstruction, where we want to be able to take a PFAS measure today and knowing how it excretes, we can back calculate to what it might have been back when they were drinking contaminated water. And if I can have the next slide, please. And while we're waiting for the next slide, So when the next slide comes up, it's going to be our list of some of the tools and resources we have available. This includes our PFAS exposure assessment technical toolkit that I mentioned before, our toxicological profile on perfluoroalkyl substances. It's unfortunately still in draft form, but it's still a good document. We have a number of fact sheets online. We have guidance for physicians, and they're all available through www.hsdr.cdc.gov/PFAS. And I noticed we just got kicked to my screen, so I'm wondering if we went too long.
Hey, Pat, nope, you're good. I'm just switching over the presentation.
Okay.
So I'm gonna, all is good, continue.
Okay, so if we can go to the tool and resources slide, actually go to human health effects slide. That'd be slide 25. Great. So I just want to briefly review some of the human health effects. And so probably one of the most profound effects is immune system dysfunction. And the National Toxicology Program, which is run by the NIEHS, has recently systematically reviewed all the human animal data for PFOA and PFAS. And both compounds they concluded were presumed to be immune hazards to humans. So what the effect was, they decreased antibody response to vaccines. Now, what that means in terms of your increased risk for infectious disease is probably not clear, but it's pretty strong evidence that it affects your immune system. If I can have the next slide. So there's also evidence that it affects cholesterol. EPI studies have identified significant positive correlations between serum PFOA and PFAS and total cholesterol in specific populations. Residents of communities with high levels of PFOA in drinking water and people who were also occupationally exposed show that there was increased cholesterol levels. But similar with the immune function, while we know that it affects the immune system, we're not quite sure if it affects your disease, your infectious disease risk. While we see changes in cholesterol metabolism, we're not quite sure whether that results in cardiovascular disease or not, increased cardiovascular disease or not. Have the next slide. Now, with respect to cancer, the International Agency for Research on Cancer, or IARC, has classified PFOA as a 2B, possibly carcinogenic to humans. And we know that workers exposed to PFAS and residents living near PFOA production facilities have experienced increased testicular and kidney cancer risk. So there's a lot of concern about the carcinogenicity of these compounds. And remember, we're really talking about, we know a lot about PFOA and PFAS, but we know precious little about some of the other commonly occurring chemicals, and certainly we know almost nothing about the vast majority of chemicals in the PFAS family. Can I have the next slide, please? So there's a range of other health effects that have either been shown in humans or in animal studies. Most of these data come from animal studies, that we can have elevated serum uric acid levels. It can affect your liver, your kidney. It can affect your endocrine system. It can affect your thyroid levels. There's a suggestion of reproductive effects, reduced birth weight, neurodevelopmental effects, ulcerative colitis, and asthma as well. So it's quite remarkable the range of possible organ systems that could be impacted by these chemicals going forward. So you put this wide range of exposures, the fact that exposures are very common across the country, and you see the possible health risks that are there, and you can see why communities are concerned and why there's a public health concern around these chemicals. Can I have the next slide, please? So while we don't know a lot conclusively about what health effects are present, I think we do know enough to tell people to limit their exposure where it's easy to do so. So we're fortunate that in many cases, for the vast majority, a lot of the PFAS chemicals can be removed with granular activated carbon. And certainly reverse osmosis and other high pressure membrane processes are more effective reducing a wider range of chemicals. We know that for babies, you don't have to mix your formula with PFAS contaminated water if you're using formula. But we also want to recommend that we're not suggesting that women shouldn't breastfeed. There's a strong, powerful literature of the health benefits of breastfeeding. And so we wouldn't want to imply that while there's concern about breastfeeding as a possible route of exposure, we don't want to imply that people shouldn't breastfeed going forward. And so our recommendation is not to stop breastfeeding going forward. But certainly if you switch to formula, you can be careful about the water you use. We know that where fish are contaminated, there's local fish advisories. And we know knowing something about what's in your consumer products, you can make informed decisions based on your own inherent risk tolerance about whether you want to use products with PFAS in them or not. Kind of next strategy, please. So we're at the front lines at ATSDR of this community outrage around this issue, and communities are outraged about it when they find out it's been in their drinking water for many decades and nobody told them about it, and they find out they got elevated levels in their body relative to the rest of the country. There's a lot of anger associated with that. So this growing community concern is something that we have to deal with every day, and all you can do is tell people what you know, what you don't know, and be honest and open about it. But we do need more health information, which is why we're doing our health studies to help add to that health burden. And while there's a lot of animal studies, and we want animal studies to continue, particularly looking at mixtures, we want to know more human studies going forward. We need to expand the environmental and biological sampling and availability of methods going forward. So if we could do everything like Michigan did, what would that map look like? Going back to that map we talked about before. We need to understand what the health effects mixtures are. That's a huge problem right now. We're exposed to not just 1, 2, or 3, or 4, or 5. We're probably exposed to many of these compounds. And we do that new compounds are being created every day and used every day that we have to keep track of. So I think I'll just stop here and see if, since we got a late start, if there's time for any questions or discussion or how we'd like to do that. I can stay on if we need to. I apologize for any sluggishness of the presentation going forward. We're all learning to live with this new reality going forward.
Thanks, Pat. Thanks for a very informative webinar and for being a trooper and sticking with our burping internet today. So as Pat mentioned, we'll now move on to Q&A. If you have a question, please type it into the question box and I will read them for Pat to respond to. So Pat, there is a question in the chat box in regards to have any of these PFAS chemicals been found in air?
Yes, so the shorter change PFAS chemicals can be more volatile and can be found in the air. And so that's an important route of exposure that we're just beginning to address going forward. There's not a lot of data on it. It's something that the EPA is pursuing aggressively going forward. So that's something that's important that we have to think about more aggressively. Now, we haven't looked at it too much in ATSDR because most of our work has dealt with the legacy of contamination through drinking water systems, but it's something that we're following very carefully, and we're looking forward to seeing data as it emerges on that, and we'll incorporate airborne inhalation risks as we learn more about it in our health assessments.
Okay, thank you. And the person also asked, so are there any methods available that could be shared?
Yeah, so all our blood sampling methods are available online, and in addition, our lab provides quality control materials to other labs across the country. So there's now a dozen labs or so that we think have good enough quality assurance for blood and urine assessment going forward, and all that information is on our website. If you go back to our www.atsdr.cdc.gov/PFAS, you'll see that on there, as well as our clinician guidance stuff. And then the water sampling methods that we put on our website are methods we got from the Environmental Protection Agency. And so the EPA is constantly updating their methods as well. And so the EPA would be a good source for water sampling methods as well.
Okay, thank you. Any plans to study the health of children born to women who were exposed during pregnancy?
So we're going to look at that in our multi-site study to the degree that we can. It's not designed to look specifically at that, but that's one of the, there's a whole host of things that need to be studied. There needs to be a longitudinal study of children who are exposed in utero and follow them through life. And so that's one of the things we're proposing to do should more resources become available to do that. So that would be an important study to do. And while we might have some hints in a cross-sectional way in our multi-site study, that cross-sectional design is probably not the best design for answering that question. And we hope to get resources to do it better.
Okay. The next question asks, the range of exposures in the Penn study was wide with some that were quite high. What did you tell the participants?
So every participant got their individual letter that said the same thing as everybody else. And if people had special concerns, we gave a number that they could call and we could talk to them in more detail about the results. So all we could tell them now, unfortunately, is here's what your result is. And here's how you compare to everybody else in your community. And here's how you compare to what we know about the general public going forward. And we say that this information will likely be useful in the future as we learn more about what these health effects are going forward. But for now, that's why we're doing a study.
Okay, thank you. The next question asks, you mentioned there is a need for more human health studies. What are some of the key questions that need more research?
Yeah, so cancer is a big one. Cancer and developmental effects in kids, when we talk to communities, those are the two big things that communities are most concerned about. When you talk about cancer, obviously that's a huge source of anxiety in a community. And when you talk about kids, obviously you raise the risk concern an order of magnitude as well. So effects on kids and effects on cancer are probably the two biggest things we need to look at going forward. But there could be profound effects, for example, on looking at cholesterol levels and cardiovascular disease risk. If that translates to increased cardiovascular disease risk, that could be important as well. And also knowing that, especially now that we're in a situation where we're worried about, the infectious disease and a pandemic, if PFAS really diminishes your immune capacity in a way that puts you at increased risk for infectious disease, that could be huge also. Now, we don't know that yet, and I want to be clear about that. We do know that it attenuates your response to vaccines, but we don't quite know how that translates into more broader immune system function.
Okay, great. And the asker also had a follow-on question to that of who do you think is best positioned to do this kind of work?
So it takes a number of people to do this work. So EPA is doing a lot of work. Department of Defense is doing a lot of work. CDC, HSCR is doing a lot of work. So we need to all work together. NIEHS funds a lot of investigator-initiated work through universities. That's an important source of our data and our understanding. So we're funding the sites to do our multi-site study. So all those people add to the pieces of the pie that hopefully help us understand what we're seeing here.
Okay, great. There appeared to be an impact on PFAS on endocrine dysregulation and obesity. Is this being followed?
Yeah, a number of people are looking at that. We're not particularly looking at it, but there's a number of other federal agencies that have taken that on, as well as other investigator-initiated work going forward. So the whole metabolic disorder issue is a hot area of research right now. More broadly, there's a lot of studies ongoing right now, and those studies, if they have blood samples archived, we could easily add a PFAS measurement to those studies going forward. And we've been approached by a number of investigators who have access to studies like that, if we can assist them with that.
Okay, great. There's a question here on psychosocial stress asking, could you expand on how psychosocial stress is examined?
So that's not something, we know that there's a lot of stressors on communities, and stress is an effect modifier in many ways. And just in general, if you can reduce stress, you can improve the quality of life for people a ton. And so we don't think HSCR, we have good tools for that. That's part of why what we're trying to explore right now. We're trying to understand the stress, how do you mitigate that stress? And that would, by the way, apply to a whole host of things, not just PFAS going forward. So we're just starting down that road, so we don't really have those answers yet, but that's something we're working towards.
Okay, great. One of our analytical chemists asks, which is better, urine or serum for biomonitoring?
Well, it depends on the half-life of the chemical in people's bodies. The longer half-life, the blood is better. The shorter half-life, you need urine for that. So the smaller chain PFAS chemicals are eliminated relatively rapidly, and you need a urine sample for that. The problem with that is, though, it's a hit or miss kind of sample if your exposure is intermittent. So if you're exposed today because you used, I'll make up an example, because you sprayed some water-resistant coating on your hiking boots before you went on a trip, you might be exposed today. And if we did a urine sample in the next couple of days, we detected it, would come back a month from now, we wouldn't have detected that. And so, the short-term biomonitoring is always problematic, but urine would be the preferred route for the short chain, short half-life PFAS chemicals.
Okay, I have a similar question here. What do levels in urine tell you that are different from what you measure in serum?
Well, you look for different things essentially. you look for both of them, but you won't see a short half-life chemical in the blood at all, and your only hope is to look for it in the urine in a time window when it's appropriate for when the exposure might have occurred.
Okay. Any studies focusing on exposure and health effects in firefighters?
So that's a big concern. Firefighters obviously are at the front line in many of that work. On the other hand, they're wearing protective gear in many cases, but many times when the fire's out, they're cleaning up without protective gear on, and they may be playing, walking through the stuff. And in many cases, their turnout gear has PFAS in it as well. And so there's many levels of concern for firefighters. So that would be an occupational effort, and HSDR wouldn't do that. But I know our colleagues at the National Institute for Occupational Safety and Health, NIOSH, are interested in that, as well as the Department of Defense is interested in that because they have a lot of firefighters in the Department of Defense. So there's ongoing efforts in that regard, but they're being done elsewhere.
Okay, there's a question here in regards to PFAS compounds and medical procedures, asking, should we not reassess the use of PFAS during surgery given the relatively new information on immunity dysfunction related to the PFAS exposure?
So that's a complicated question, and I'm certainly not in a position to answer that because there's trade-offs there. Obviously, there's benefits to what you need to do and what you use things for in that situation. And given the known benefits and the uncertain health effects, that would be a difficult calculus to make. But in the future, as we learn more, that'll be something we probably need to kind of focus on. But at this point, I think the medical benefits of the procedures, are known and quantifiable, and health risks are probably uncertain enough at this point that I don't hear people saying stop using these materials containing these chemicals. And in addition, if you have a Teflon something or other, the PFAS chemicals are pretty tightly bound in the Teflon, and it's probably not a big source of there's probably not a lot being released from a well-cured, well-made Teflon by itself.
Okay, there's a question here related to water treatment methods. Is it safe to assume that there are no known clinical treatments for exposures to high level of PFAS compounds?
So I don't know what you mean by no known clinical treatments. If the question is there a way to remove PFAS from your body? There's nothing that I'm aware of that is routinely being recommended to be used. We know that, when you lose blood, you can lose your PFAS levels, but nobody's going to recommend bloodletting as a way to reduce exposure going forward. So I think there's nothing that I'm aware of right now that suggests a way to remove PFAS from your body. But, if you do have, thyroid effects, there are treatments for thyroid effects. If you do have cholesterol effects, there's treatment for cholesterol levels. And so in many cases, these are changes that occur because of lots of other things in people's lives as well. And so that's part of the difficulty in teasing it out, is that there's lots of reasons why people can have high cholesterol levels. There's lots of reasons why people can have, hypothyroidism. And when is it caused by a chemical you might be exposed to versus all the other myriad of reasons that might have produced it. That's why these things are so tough to follow and understand.
Great. And the last question in here is it possible that water can become polluted with PFAS when it's in the water distribution system?
Well, you know, that's not my area of expertise, but I'm just trying to think off the top of my head. You know, we know a lot about how PFAS moves through water distribution systems, and I've learned a lot more about it since the Flint water crisis going forward. I'm just thinking, I can't think of a way that PFAS can get into a water supply once it's in the distribution system. I just can't think of that. The focus has been on the source water and what's in the source water, not what happens in the distribution system. Other than, you know, a complicated distribution system can have multiple sources of water with different levels of PFAS, and so it's complicated if you have one well that's contaminated with PFAS and one well that isn't, and you have a water distribution system that mixes water from those two sources at variable rates depending on time of year and demand and so forth. It can make understanding what might actually come out of the tap complicated, but all that is just about the source water, not about the distribution system per se.
Okay, thank you. So that's those are all the questions we have. So thank you everyone for participating in this month's webinar. Within the next day or so, all the participants will receive an email from ISES asking you, that it will include a link asking you to evaluate your experience with this webinar. And please remember that the recording of today's webinar, along with any handouts, will be posted behind the ISES member shield. So if you're not a member and you'd like access to the slides, please consider joining the society. And a final reminder, abstract submission and registration opens on March 25th. That's tomorrow. So, and the abstract submission will close on May 18th. And that's for the ISES annual meeting in Oakland, California this September. So thank you very much, everyone. Have a great day. Thanks, Pat.